guys, this is Eric Zevallos. I'm coming at you to talk about lower extremity venous ultrasound today. The lecture plan, we're going to start off by talking about the clinical significance of deep vein thrombosis and why it's important to us. We're then going to talk about the purpose of ultrasound and the diagnosis of the DVT. We'll talk about bedside or emergency care ultrasound and how it compares to the radiology performed ultrasound. We'll then get into performing the actual exam, image acquisition and interpretation, talking about the equipment, the setup, and the patient positioning, and common pitfalls when performing the ultrasound. And we'll wrap up by talking about the clinical decision making and how DVT ultrasound can change our practice and be utilized in our practice. So let's get started and talk about the clinical significance. Every one of us has seen this patient, whether it be in the emergency room or in our private practice, where a patient comes in presenting with unilateral isolated lower extremity swelling. Now, what are the odds that this is a DVT? Well, as you can see, DVT is pretty common. It occurs in approximately 80 in every 100,000 patients. Many of them go undiagnosed. Specifically for emergency medicine physicians, about 7% of all ED visits are secondary to a lower extremity complaint. So why use ultrasound in the diagnosis of DVT? Well, clinical diagnosis, it's practically a flip of a coin as to whether a patient has a DVT or not. The classic findings, which were taught in medical school as pain, tenderness, and unilateral leg swelling, are all very insensitive. When all of these findings are present, the chance of having a DVT is 50% or less. The flip side is also true, in that patients that do have a DVT, frequently only one or maybe none of the classic findings are present. Now, modalities that were used prior to the introduction of ultrasound, such as contrasted venography, used to be the gold standard. It's highly invasive, and in 10% of patients that undergo this, they actually develop a DVT. CT venography, very sensitive, however, the exposure to radiation is often not necessary. And then MRI, though very highly sensitive, is very difficult to attain and is very time consuming. If you are a physician working in a resource-limited setting, in all likelihood you will not have access to these diagnostic modalities anyway. Therefore, ultrasound becomes the go-to diagnostic tool. So that brings us to ultrasound. It's currently the initial diagnostic modality of choice. It's most sensitive when a patient comes in symptomatic from their DVT. Ultrasound is highly sensitive and specific. You can see the numbers there. And overall accuracy, depending on the study, is quoted between 96 to 98%. There is a weakness to ultrasound in that it does have low sensitivity when looking for calf veins or pelvic veins, such as your iliac DVTs. And we'll talk a little bit more about this later and why this is important. Now, there are definitely some differences between the way the emergency physician approaches DVT ultrasounds and the way that the radiologists approach DVT ultrasounds. So starting with the emergency medicine physician, we use ultrasound techniques solely via the compression method, while radiology use compression but also use color and spectral Dopplers to help determine if there is a DVT present. The bedside ultrasound, we only visualize the common femoral, the superficial femoral, the deep femoral, and the popliteal veins, whereas radiology evaluates all of those veins as well as the calf veins. And then the time, there's a big difference between the time. The emergency physician or bedside ultrasound only takes minutes. Once you get well at doing it, maybe 2 or 3 minutes, while sending a patient up to radiology to have an ultrasound performed can take 45 minutes to up to an hour and a half sometimes, depending on the availability. Now, looking at the setup, we're going to be using the linear probe. This is a vascular probe. It's the rectangular, long-shaped probe. And we're going to be using the setting of the vascular setting or venous setting. Patient position, we're going to try to orient the patient to expose as much of the upper leg as possible because we're going to be trying to get up into the inguinal area. And you want the veins to be as distended as possible. So we're going to have the patient supine and have the head of the bed elevated to about 45 degrees. Now, sometimes when it's difficult to evaluate the veins, you might have to use some adjunct positioning, such as having the patient stand up to fully dilate those lower extremity veins, or have the patient go prone and have their leg flex just a little bit so you get better visualization of the popliteal veins. And this is what we're looking for. So in the transverse view, you're going to have a circular structure. And in this case, you can see the vein is lit up here with color Doppler and the artery right next to it. And if you turn long axis on that, you can see the bifurcation down here of the common femoral separating into the deep and the superficial. And the way we're going to determine if there's a DVT or not is to look in the transverse view and to perform a technique called compression, where we put direct pressure onto the vein and watch it collapse. If the vein does not collapse 100%, then you cannot say it is a normal vein. Every time you move the probe, it's important that you do compress so that you do not miss a subtle DVT. So this is just a review looking at the normal anatomy. Right here is your common femoral vein, and as you can see early up in the inguinal area, you're going to have a split between the common femoral vein and the saphenous vein. This is going to be the first landmark you're going to look for, is that bifurcation of the saphenous off of the common femoral. And then just a little bit distal to that, you're going to have the bifurcation of the deep femoral and the superficial femoral. So those are the 2 points that you're looking for when looking at the upper portion of the lower extremity. And then you're going to come down and look right behind the knee at the popliteal vein in this area. And you're going to first see the popliteal vein sitting right above the popliteal artery and follow it down to the trifurcation. Now, as I mentioned before, in point-of-care ultrasound, we are not looking at the superficial veins in the calf. Here are the views looking with an ultrasound, the common femoral vein and the saphenous right here. And this is what you're going to be seeing, the saphenous vein bifurcating off the common femoral. The next view you're looking for is the bifurcation of the deep femoral vein and the superficial femoral vein. And lastly, you're going to be looking for the popliteal vein. Remember I said it sits right above the popliteal artery, so that's a good landmark to use. Now again, the vein must completely collapse to be negative. If the vein does not collapse, then you have concern for DVT, vein scarring, improper technique, or a physiological state with high venous pressure. So the first image that you're going to be trying to acquire is that of the common femoral and the saphenous bifurcation. Okay, so saphenous bifurcates early up in the inguinal canal. So here's your common femoral vein, and here's your common femoral artery. And as you can see, the saphenous bifurcates very high up in the inguinal crease. So that's the first image that we're going to be looking for. And then you compress. Okay, so next we're going to come down to where the common femoral vein bifurcates into the superficial and deep. And as you can see here, you have your common femoral vein. And as he slides down the leg, it's going to break up into the superficial and the deep. Right there. So there's your superficial vein, and there's your deep vein. Now as we go through this again, I want to bring your attention to something that pops up in the right upper viewpoint of the ultrasound. Right there. I'm going to freeze it. This is a very common pitfall, and physicians often mistake this for a DVT, but that's not a DVT, that is a lymph node. And the way you know that is if you look in 2 planes, you're never going to see the long axis view of the vein that you would expect to see. It's always going to look like a circular structure. And the last view is the popliteal view. So remember, you're behind the knee, and it's going to sit right above your popliteal artery. So right there in view is your popliteal vein. And as you come more distal, it's going to trifurcate into your calf veins.
For the DVT exam, we're going to use a high-frequency linear probe. We're going to demonstrate a 3-point compression technique for detecting proximal DVT. The probe is going to be placed just below the inguinal crease with the probe indicator facing to the patient's right. Femoral artery can be seen here. It's a pulsatile structure when you apply light pressure. As you relax, you'll see the common femoral vein. The common femoral vein is here, and you will need to slide up or down the leg until you see the saphenous vein join. You can see the saphenous vein right here. We'll slide just above the confluence of the saphenous vein and the common femoral vein and compress. And you can see that the walls of the common femoral vein compress all the way down. We'll slide back down to the confluence of the saphenous vein, the common femoral vein, and we'll compress again. And we'll slide just below the confluence and compress one more time. And you see the walls of the common femoral vein are touching each other. Once you're satisfied that the common femoral vein at the confluence with the greater saphenous vein is fully collapsible, you'll slide down to the confluence between the superficial and deep femoral vein. If you're having difficulty identifying the anatomy, oftentimes it's because the subject is lying flat and there's low luminal filling pressures in the venous system. So you can have the subject sit up. This will provide impedance to forward flow in the venous system, and this will cause the veins to dilate. And obviously it'll be a lot easier to visualize. So now we can see the common femoral vein here. And as you slide just inferior, you'll see common femoral split into the superficial and deep femoral veins. Compress here, and you see both are completely collapsible. When you're trying to collapse the deep femoral vein, a lot of times you'll have to apply significant pressure because the deep femoral vein has a lot of redundant tissue overlying it. Lastly, we're going to compress the popliteal vein. To acquire images of the popliteal vein, you simply place the probe in a short axis relative to the leg and the popliteal fossa. Once you do this, a lot of times you'll see pulsations of the popliteal artery, which you can see right here. The popliteal vein is almost always anterior to the popliteal artery. As you compress here, you can see the popliteal vein is fully collapsible. And we'll follow this down all the way to the trifurcation to make sure all components of the venous system are compressible. You can see trifurcation here, and the venous system is obviously fully compressible when I apply pressure. A lot of times you can put your hand on top of the patient's knee
to provide a little extra support, making it easier for you to compress the vessels and more comfortable for the patient.
All right, so now that we've talked about all the normal findings, here are the few abnormal findings that we'll come across when performing the lower extremity DVT scan. Clearly what we're looking for, the deep vein thrombosis, is the first abnormal finding we'll find, but also lymph nodes, which we talked a little bit about, and the popliteal cyst. So first let's take a look at what a DVT looks like. So here's an example, and as you can see, as they scan through this, you can see that there's a bifurcation right here, and that is your saphenous coming off of your common femoral. You can see your common femoral artery over here. You can see there's a hyperechoic area inside the vein. And when he compresses, you can see they compress hard enough to cause collapse of the artery, and yet there's no collapse of this vein. So that is a DVT. Now in this case, you can see thrombus located within the lumen of the vessel, representative by this echogenic material right here. However, I want you to resist the temptation to rule out a DVT when you do not see this echogenic material within the lumen of the vessel. Oftentimes, an acute DVT will present and there will be no echogenic material within that lumen. All that you will see is a non-compressible vessel. When you start to see this echogenic material within the lumen, it becomes more representative of a subacute DVT. Here's another example. Again, we're high in the inguinal crease. This is your common femoral, your saphenous takeoff. And in this case, you can see that there looks like there's hyperechoic material in both the common femoral and the saphenous vein. And again, you see that there's two arteries over here, and they compress hard enough to compress those arteries, yet neither one of these veins are compressing. So those are DVTs in both the common femoral and the saphenous vein. Now I want to go ahead and take a moment to talk about the saphenous vein right now. Though the saphenous vein is not a deep vein, when you have a clot burden in the very proximal portion of the saphenous vein, we do consider that a DVT. A clot in the proximal saphenous is treated as a DVT. Okay, and here's another example of a free-floating thrombus. Again, we're in the popliteal region now, so you can see your popliteal vein right here. We just turn long axis on it. So again, here's your popliteal vein. Now it appears to be pulsating, but that's because the artery is pulsating right underneath it. And you can see there's a thrombus burden right there. So we'll take a look at it one more time. He compresses. There's a little portion of the vein that's not compressed right here. And when you turn long axis on it, you can see there's free floating material here. And though we don't use color Doppler for the diagnosis of DVT, when we apply color Doppler here, you can see there's no blood flow around the clot. Here's one final example of a clot burden in the popliteal region. So popliteal artery sitting here, it's pulsating. And here's your popliteal vein. You can see there's hyperechoic material within the lumen, and when they compress, there is no compression. And they're placing enough pressure to collapse that artery a little bit, so you know there's a DVT there. Okay, so what if you see this? Say a patient comes in with pain in the popliteal fossa or the calf, and while conducting your typical ultrasound protocol for DVT, you notice this structure right here. Now this looks dramatically different than a DVT, correct? This is not a vein, it's a large cystic cavity. And this is what a popliteal cyst looks like. This would be one instance where we would recommend using color flow Doppler to make sure there is no blood flow in this cystic structure, because on your differential diagnosis includes popliteal artery aneurysm. So popliteal cyst, also known as Baker cyst, it is a synovial fluid-filled sac, usually in the popliteal fossa. So this is where you'd be looking. If you see a fluid-filled structure, the likelihood of that being a Baker cyst is high. Now we're going to talk about clinical decision making and how we can apply the principle of DVT to utilize it in our practice. Remember, be conservative when determining if there's a DVT or not. If the vessel does not collapse, assume it is a DVT. And before we talk about that, let's talk about calf veins, because we talked about before at the beginning how when we're doing point of care ultrasound, we don't go and scan the calf veins, but the vascular lab or the radiologist, they do. And what's the difference and why do we do this? Well, calf veins are not considered deep veins. So when we're looking for a DVT, it makes sense that we wouldn't be looking in the calves for DVTs. Now, approximately 20 to 30% of clots in the lower extremities do occur in the calves. Approximately 15 to 20% of calf veins will propagate if there's a thrombosis into the deep venous system. So that's why the calves have the importance. That's the reason that the radiologists perform the calf veins. But one of the studies done in 2008 by Bernardi took a look at doing 2-point ultrasonography plus a D-dimer versus the whole leg color Doppler performed by radiologists to see if there was a difference in venous thrombotic events after a 3-month follow-up period. This was a large study. It was done in Italy. There were 2,500 patients, and they were randomized to either 2-point ultrasound plus a D-dimer or whole leg ultrasound. Now, the patients that were randomized to the point of care ultrasound, they had an initial negative DVT scan, they received a D-dimer. If the D-dimer was negative, so they had both a negative DVT scan and a negative D-dimer scan, these patients were cleared from the emergency room and followed up in 3 months. If the patient had a negative DVT scan but an elevated D-dimer or no D-dimer was ordered, they had a repeat scan in 1 week. Now, it's important to realize the 1 week follow-up is in order to rule out that propagation of a calf vein into the deep venous system. So all the patients with either an elevated D-dimer or no D-dimer have this 1 week follow-up. At 1 week, if that repeat scan was negative, then these patients were cleared and were followed up in 3 months, similar to that first group. Now, when looking 3 months out after the study, they compared the point of care ultrasound group to the radiology group, and symptomatic venous thrombotic events occurred in 7 out of 800 patients in the 2-point strategy group, the point of care ultrasound group, versus 9 patients out of 760 patients in the radiology or whole leg strategy group. So the conclusion is that between these two, the diagnostic strategies are equivalent when used for the management of symptomatic outpatients with suspected DVT or lower extremities. In other words, at 3 months, the odds of having a venous thrombotic event, which is truly what we're trying to exclude, are practically the same. Now, what is the role in D-dimer? So, because we just talked about that in our prior study, well, the role for D-dimer is it can be used reliably to exclude venous thromboembolisms in the setting of a negative DVT scan. And as you can see in this study, in patients with a low pretest probability for DVT and a normal D-dimer, the negative predictive value was 99%. So as far as our clinical decision making, the patient comes in with that unilateral leg swelling and we perform a DVT scan. If our ultrasound is positive, then we go ahead and manage the DVT as we would always with anticoagulation. If our scan is negative, then you have to make the decision, is our patient low risk or is our patient moderate or high risk? If the patient is low risk, you can either get a D-dimer. If that D-dimer is normal, then the patient has no DVT and you can have routine follow-up. If the patient has no D-dimer or an elevated D-dimer in the setting of a negative ultrasound, then they need a repeat ultrasound in 1 week. And then any patient that is moderate or high risk probability, they need to have a repeat ultrasound performed in a week. So now let's talk about pearls and pitfalls. So one of the most common pitfalls that we see is that physicians consider the superficial femoral vein as a superficial vein, and that's not the case. Despite the nomenclature, and I understand it's confusing, but the superficial femoral vein is a deep vein. So if you have a clot burden in the superficial femoral vein, it needs to be treated as a DVT. Next, what do we do after a negative ultrasound? Like we talked about before, in the low clinical suspicion or low probability group, a negative D-dimer and a negative ultrasound is sufficient to say there is no DVT. All others that have either a positive D-dimer, no D-dimer, or the high or moderate risk population need to have a repeat ultrasound done in 5 to 7 days. Failure to properly position patient can cause problems with image acquisition. So remember, try to distend those veins as much as possible. Having the head of the bed elevated will help distend the veins. And if it still is difficult to evaluate, have the patient stand up, further distending those veins. Many times when you're in the popliteal region, it might be difficult to compress the vein, not because there's a DVT, but because of the adjacent structures, whether it be bones or tendons. In order to overcome this, you might need to apply pressure from different directions in order to compress the vein. Misidentification of lymph node as a thrombus is probably the largest reason for false positive results for DVTs. Again, if you have a circular structure that's not collapsed, take a look at it both in transverse and longitudinal. If it does not look like a tubular structure when you turn longitudinal, then it's not a vein. If you have a structure that looks like a circular structure or an ovoid structure in both longitudinal and transverse, it's likely a lymph node. And here's an example of a lymph node. So you can see one up here. And again, this would not compress. And we talked about this before, but remember, proximal saphenous vein thrombosis is considered a DVT, so treat as such. You might also, if you do this commonly, start to see patients that have duplication of their deep veins. This is not uncommon, so beware of a thrombosis in 1 or 2 of the common femoral veins if there is a duplication. So to conclude this lecture, a limited ultrasound protocol of the lower extremity is as good as a complete protocol and takes less time, so we don't have to always rely on radiology to perform these. Emergency physicians have adequate sensitivity to perform this exam. Lack of compression means this is a DVT. Be conservative when performing this exam. Always compress in short axis. Don't try to compress in longitudinal axis. Never rely on visualization of a thrombus. So you might have a thrombus but not be able to see that hyperechoic material inside the lumen of the vein. And depending on your clinical suspicion, your patient may need a repeat exam in 5 to 7 days if they're a high, moderate risk population or they have a positive or no D-dimer.